But what I am going to do in the next 20 minutes is give you a sense of my own career and the way that my own research has fed into my thinking and in relation to advocacy and awareness. And so just the research finding, I'm not going to talk about my research findings. If you are interested in them, I'm very happy to talk about them afterwards. But I'll just I'll kind of mention them in passing. So I came through a career in medicine before I moved into public health. But I thought that it would be interesting, possibly, to give you a sense of, that's a bit too big, give you a sense of that trajectory. And I know that you are from highly diverse backgrounds, so this would probably seem extremely alien to you and maybe of no interest, but I hope it is. So I, as a grammar school girl, high school girl, I had access to the New Scientist in the library in the sixth form college, and there were only 30 of us. Only 2 of us went on to university. So I come from a different era, as it were. And in those New Scientists, I read about climate change and a lot of the things that are in the daily newspapers. And I became quite a passionate environmentalist at that time, and I still am, but I also wanted to do medicine. And so medicine became my primary passion, and I trained as a medical student. And then I came across epidemiology, which is the study of the determinants and distribution of disease in populations. And of course, the flip side of that is the determinants of well-being and contentment and good mental health. And the idea of bringing the environmental interests that I had and medicine together was very, very appealing. And so I went to the professor of epidemiology at the time. This was one of the London medical schools. And he said, "Go and become a proper doctor. I'm not interested in you now. Come back when you've become a proper doctor." So when I finished my medical training, I went on into general medicine and neurology and a bit of psychiatry, and I went back to him. And he then did support me to get a Medical Research Council training fellowship in epidemiology, and training in epidemiology. So that is the pure science of epidemiology, the study, as it were, the etiology of disease. And I loved that idea of detective medicine, as it were. And so then I started a career in epidemiology, and my chosen area was aging, and I'll come on to that in a moment, to look at the relationship between normal brain aging and pathological brain aging. And at that time, this is a long time ago, before some of you probably were born, there wasn't that much interest in dementia. But my interest was how does brain aging in, as it were, usual populations work itself out? Some people become demented, some people don't. What's the relationship between what's going on? What's the biology, what's the early history, what's the trajectory, and so on. And so that became my career research trajectory itself, because dementia is an all-consuming condition in a way, and I'm sure you've all heard a lot about it. So that was what brought me. Then I came to Cambridge, following my husband, who got a job here. And the person who had promoted me in London, when I went to tell him that I wanted to move to Cambridge, he said, "I'm never going to support a married woman again." You wouldn't get away with those views now, would you? He was actually extremely kind. He let me move to my whole fellowship up here. And during the time in Cambridge, we've moved from being a tiny department doing virtually no research to a huge set of departments which are doing research which ranges from physical activity and obesity and diabetes right through to policy and health improvement, for example. So there's been a lot of development during my career. So that takes me into the mid-career stages. And when I was in the mid-career, I became a lecturer here, and I had to, as that, set up a master's in epidemiology. That was part of the job. So I set up the master's in epidemiology, which is running still, and that started in around 1993. And what that taught me was the power of training and education and influencing individuals and trying to provide the next generation and the next generations with skills and approaches to research, but also to life in this case, public health, which will carry them through their careers. And that was a tremendous privilege from which I stopped doing that quite a few years ago now, when I became the director of the Institute of Public Health. So when I come into my later career now, sort of the tail end of the career, I've got the research pillar of the brain aging and also a certain amount of psychiatric epidemiology type work. And then I've got the generic public health, because I had to learn public health through teaching. And I had the original interest in the environment. And I'm just going to tell you just a little bit how it all has come together. So, on to aging. So it turned out that I had chosen a research field that moved from being highly unfashionable to being extraordinarily fashionable. And so everybody is aware of the huge change in the demographic profile in the Western world, that we have far more of the population are in the older old than used to be. But it's also happening across the globe. So we're going to see vast numbers, because we have this increased population, we have increased survival, and so we're going to have a much, much larger, older population, which means from a research point of view, we really need to understand the determinants of healthy aging, and certainly from a pure epidemiology point of view. And this is so what my research has taught me over the years is that it's the current research paradigm is slightly it's intuitively important, but actually it's opposite to what we need in a way. Because what happens with age is that we accrue different disorders, but in our research worlds, we look at specific single disorders. And in industry, particularly pharma industry, up until very recently, there's been a focus on younger people with disorders, and in trials, older people are not represented in trials. So in terms of doing research in older populations, I've become, with my public health hat, very aware that it's incredibly important to promote the importance of understanding what the real needs in the population are before you try to apply your research findings to ensure that they are actually relevant to the population that you think needs those, whatever it is, interventions or pharmaceuticals. And so a really good example of that, I don't know whether any of you work in the pharma industry, but it's taken decades for us to become aware that most older people have more than one condition. And that means that most of the trials that have been done on people who don't have other conditions are not relevant to those people. So it is really important that we construct an evidence base for ourselves in the future and for the current older population that is relevant to them. Because if we are prescribing as a GP or whatever, we want to know that the thing that we're prescribing is not going to do harm. So this is one of the sort of areas where, if you're doing research, it might not be specifically about that thing, but it teaches you about something more general, and then you can use the linkages and the networks that you have to try to influence what's going on in other areas. So that's a kind of advocacy type of thing. So the aging of the population in the world is very, very relevant. And one of the things that I have learnt, particularly here, is that a lot of the research that we do, a lot of the things that we do, we need to think, how relevant is this for different populations? Is it relevant to people in lower and middle income countries? Are there things that in those societies, public health could be doing things within those communities for the same amount of money, which would have an enduring impact, which would only have a minimal impact if applied to, say, a specific disorder? And so that's a very strong area of public health, is trying to use our resources, limited resources, well, because if we spend them in one area, we're not spending them in another. And that's really important. And I think sometimes when the profit motive is very strong, it can override the aspect of who is going to benefit from what it is that we're doing. And the biomedical industrial complex is very powerful in that regard and makes a very strong narrative about benefit. But we really, from a public health point of view and an epidemiology point of view, we need to be providing an evidence base that allows the testing of those statements. And I'm sure many of you have products that may fit into this kind of thinking, and it's a kind of impact analysis. So in public health, you have what's called an impact analysis, and you try and think about it from all these different perspectives. So that's aging of the population. Then in my research, I was really keen to do the neuroscience, to do imaging, and to do whatever the latest fashion is. And as over my career, I've realized that there are sort of fashions, so they come in cycles, the fashions of the types of things that we do. And we've got more and more sophisticated about the things that we can measure in people. And we do quite a lot of basic biological work. I mean, I don't do it personally, but I collaborate, huge networks of collaborators. So that's been a very important part of my career. And what I've realized is that we have these wonderful things that we can do, but we're not so good at testing how they really work in populations. And to do that, it's a bit boring and slow and expensive and so on, but it is definitely worth doing. And imaging is one case in point, because it's a beautiful technique, fantastic, really good in the research environment. We're learning more and more, but we need to be very cautious about the implementation of those kinds of methodologies into populations and into patient groups, because we really, really need to know whether they're going to lead to greater benefit or not. And they do take up a huge amount of resource. And I refer back here to the thinking about settings in which there are less resources available. The idea that, for example, in my own field, you are recommending, it is being recommended that people have rather sophisticated imaging, which is, of course, great for business. It's great for the people making the radioligands. It's great for people, for General Electric in terms of selling machines and so on. But actually, it takes energy, it takes the Earth's resources, and it's hugely expensive, and it's really very unlikely to be applicable in a lower and middle income setting, and not, frankly, even in our own NHS. So we need to really, really show that something is a huge benefit, and then we can advocate and make people aware of what's valuable for populations. But in the absence of that, we have premature translation, which may not do benefit or may not bring benefit for populations. And clearly, we know a lot about health and healthy aging in terms of what's available in society. And that's something that I found in the research that I've been part of and been privileged to lead. So I love to do this stuff I would love to have the resources to be able to do this in older populations and follow people over time to understand how people age and what influences it and what the biological changes are. We have only limited resources to do that sort of thing, but I would be very cautious about translating those methods into the population. What I'm not cautious about translating is the learning from our research, and that's where the advocacy and awareness comes in. So what I've learned in my research is that there are some generalizable things that really stand out. And in aging, it's very much that it's complex, and dementia is a part of the aging process because it becomes very much more common with aging. But that means that it's also part of the dying process. And that led me to really see the aging of our populations as an organic dynamic process, and one in which we can shift. We probably can shift things. We can do some prevention. We can't do all prevention. And this then leads to the discussion about how long do we want to live, and the maximum limits of life, and what are the resources required if people if some people want to live forever, and that immediately brings you back to inequalities. So what we found in our research is that the really important aspect about reduction of risk, say, for dementia in the population is that it runs across the whole of the life course, that if you have healthy pregnancies, you have healthy children, you have a system in which children are enabled to be healthy and they are stimulated and they have optimal brain development, and then they move into early and midlife, and if you have an environment in which they're unlikely to take up harmful habits or be exposed to harmful things, that they move into midlife at lower risk of developing all of the conditions like diabetes and heart disease and stroke and so on. All of those conditions then lead into the way that your brain ages and how healthy you are in your older age. And that also has an influence on your terminal decline, on what happens at the end of your life. So people who have higher education, who have had more advantaged lives in general, have a better death. So the research that we've done, so even though it seems focused on, so for me, in dementia, it actually has opened my eyes to how important it is to have healthy life courses, and therefore, you can only have a healthy life course really if you're in a healthy society. So that's brought me back into the public health part, and that's really become an important part of my work. So that's moved me into more national roles, trying to influence the nature of research and the nature of communication and awareness and advocacy for the type of societal changes we should make and the type of research that we should do to foster those things. And this is a very famous diagram. It's quite old now, but there isn't really, it still stands. And this simply puts in one slide what I've been saying. Brain aging, you can look at all of those things and kind of see what the influences on brain aging and healthy aging would be. And so public health works at all levels, at national level, regional level, community level, local authorities, and at individual level in terms of what's the evidence base for individual interventions, and tries to assess how do we get the balance of interventions or societal change at all those different levels to optimize how we live our lives. Because really, we don't really want to be focused on the measurements of X, Y, and Z in our daily lives. What we want to do is live our lives without having to think about our health. We're living in a society at the moment where we're very focused on health, but that's a question that I didn't put into the questions to ask you. But it's really important. And we know from a public health point of view that you get a bigger bang for your buck with doing something at the population level in terms of prevention than you do by doing things at an individual level. And yet at the moment we're working very much on risk at individual levels and not at the as it were, the whole environment. And so that's the background to one of the questions, at least one of the questions that you've posed later on. So that brings me to the impact of, or the thinking. I think you covered these sorts of things this morning, and this is one exercise which looks at global challenges facing humanity. And aging, of course, is one of the drivers for the rise in the number of people on the planet, and therefore one of the drivers for the use of resources and so on. But all of these things do have an aging component. Perhaps transnational organised crime not so much, but there are aspects in which it is relevant. And so the advocacy from a public health point of view is very important in all of these areas of societal functioning. And this was brought home to me very strongly recently well, not so recently, it was in 2016, but I live in Cambridgeshire and we had a flash flood, and my neighbour lived there who we provided quite a bit of support to. He died just after he was 100, and this was a flash flood. And these are two roads. And so the public health, the urgency of the discussions about how we bring health and well-being and environmental aspects and sustainability into everything that we do was brought home, very, very strongly. And I try to, in all my work, now think about how does the research that I do and the policies that are being discussed and so on fit into the Sustainable Development Goals. And we really ought to be trying to make sure we are inching these in the right direction with everything that we do. And I try to do that in my research and in my teaching and in my integration with policy and so on. So I'm going to stop there.